Good afternoon, everyone, and welcome to NMAC's third educational webinar for the HIV 50+ Strong and Healthy program. Thank you all for joining. Before we get started, I just want to go over a few housekeeping rules. When you join the webinar, your microphones will automatically muted. If you have any technical difficulties or have any questions throughout the webinar, please type it in the chat box window. My colleague, Sable Nelson, will be monitoring the chat box window, and we will address questions at the end. This webinar is being recorded and will be available to everyone who registered for the webinar. At the end of the webinar, there is an evaluation survey. Please make sure to complete the survey. Now I'll hand it over to our presenter today, Dr. Eugenia Slider from the Division of Geriatrics and Palliative Medicine at Weill Cornell Medicine.
Thank you very much, good afternoon, everyone. Good morning in California, and thank you for joining me today. I have a disclosure. And I also want to thank my collaborators and colleagues and NMAC for the invitation to join you today. There we go. I wanted to begin by asking you to ask yourself some questions, and I hope that what we talk about will help you think about how the fields of HIV and geriatrics should work together to help you live as healthy a life as possible. So just think about these things. Am I aging? Am I old? Do I feel old? And a topic we'll get to toward the end is do I need a geriatrician? Think about all of these older people with HIV. They're quite different. They range in age, gender, medical problems, caregiving needs. Yet all of them are aging with HIV. And the challenge for my colleagues and I are, how are we going to meet everyone's needs? How do we implement care? And how do we create a program that can help all of you? So what I want to do today is divide it into 4 parts. I'm going to talk about the numbers, the demographics of HIV and aging. I want to talk a little bit about basic aging principles, and then move on to aging with HIV, and then finally talk about whether geriatrics can be helpful to you. So let's begin with some demographics, and this is a study that's about 5 years old, but remains very relevant today. It is a depiction of the demographics of aging with HIV all over the world. In the top part of the slide is all the countries except for Africa. And the blue that depicts Western and Central Europe and North America, and shows that the number of people with HIV who are 50 and older not only is increasing, but that the slope is changing, that the rate of increase is accelerating a bit. And that is true for all of these different regions. The slope starts to change right around 2010. It's even true for these areas where there aren't many people who are 50 and older with HIV. That's what this inset is. All of the slopes start to rise around 2010. And that's, I think, what we're all seeing, which is that the numbers are beginning to increase dramatically. In the inset, in the graph below, we see the populations in Africa, and the blue line is Southern Africa. The point here is not that we see necessarily the same inflection of the curve, but if you look, Southern Africa is the place where the largest number of people who are 50 and older with HIV are in the world. So about 1.5 million people with HIV are 50 and older there. People are aging with HIV everywhere. This is reflecting a slightly different aspect, which is the proportion of people who have HIV. What how old will they be? So this is a Dutch study, and the red rectangle that's all the way to the left at 2010 are the numbers that they measured at that time. Each of these different colors represents an age group. So that if you look all the way to the left, there's a small number of people who are over 70, a slightly larger number of people 60 to 70, and even larger number 50 to 60. But about 30% of the population with HIV at that time was 50 and older. I've drawn this red line across to show you what they project to be the population breakdown by 2030, and they're estimating that about 75% of people with HIV will be 50 and older, and about 10% of them will be over 70. So that in the case of resource-rich countries, not only are the numbers of people with HIV and aging growing, but the percentage is also increasing, making the population with HIV an older population. Now, one of the reasons that the population continues to increase is that a certain percentage of people who newly acquire HIV are over the age of 50. And these are data from the CDC showing that somewhere between 15 and 20% of new HIV cases are in the 50-plus age group, and about 5% are in the 60-plus age group. So that it's important to recognize that long-term survivor and older person with HIV are not exactly the same thing. There are people who will acquire HIV later in life. There are long-term survivors who may be quite young, who may have acquired the virus at birth. So that while I'm talking largely about older people with HIV, and while most of those people are long-term survivors, each group has slightly different needs, and we're trying to be as inclusive as possible. So why do older people become HIV positive? There are a number of reasons. They remain sexually active. They often don't discuss sex with their healthcare providers. And stigma and depression are serious problems at older ages, so that they are often at higher risk for unsafe sex. In addition, there is no decline in the rate of injection drug use and substance use disorders, so that there is no change in the way HIV is transmitted or the risk. So having said that, aging with HIV does differ in certain ways from acquiring HIV later in life. Again, some of these differences can be subtle, but it's worth talking about them a little bit. The graph on the left looks at medication use based on how long one has had HIV. So the curves are three different colors. The x-axis shows age, and the y-axis shows the probability of what we call polypharmacy, that is, taking 5 or more medications that aren't antiretrovirals. The blue line are the control group, that is, those who don't have HIV. And as you can see, the risk or the chances of having to take more than 5 medications increase. Those chances increase with age. If in the population that has had HIV for at least 20 years, that risk is much higher. One has the risk of someone approximately 15 years older without HIV. And in the middle, they were not able to distinguish those who'd had HIV for fewer than 10 years or between 10 and 20 years, but it is somewhere in the middle of those two risks. On the right is a graph that I made from information from the New York City Department of Health, and this is the number of people who acquired who had a new HIV diagnosis in 2016 in New York City by age. And what I want to point out is that although the numbers, the sheer numbers of people who acquired HIV decline with age, if you look at the gray bar next to the green bar, the percentage of people who presented with AIDS rather than just with new HIV was significantly higher in the 60-plus age group. So that about a third of people who presented with new HIV over the age of 60 had already advanced disease, probably reflecting our fault as providers and an inability sometimes to see that and think that someone would present at this age with AIDS, with HIV. So that clearly being infected for a long time has physiologic consequences for the body, but also presenting with severe immunodeficiency does as well. So with those sort of general descriptors of the demographics of HIV and aging, let's talk for a little bit about what happens when a body ages. And that's actually a fairly difficult thing to make generalizations about. Aging can occur at different rates in different people. Their organs can respond differently. On the left is a picture of 3 of our presidents who were in office for 8 years, and there's a myth that goes on that being a president ages you faster than the rest of the population. That's actually not true. What you do see, though, is someone who has been in office, whom we've watched for 8 years and taken a lot of pictures of for 8 years, and you get to see aging very clearly. On the right is Betty White, and she's just reminding us that, again, how she has aged is going to be different from how others have aged, and how she feels about aging is how she feels. We know that aging in general leads to diminished reserve. That diminished reserve makes us more susceptible to injury as we get older, and it makes it more difficult for us to recover, often makes the recovery time longer. We also know that many of these changes are preventable. This can happen in any organ. What I'm showing here is muscle, and you may have heard the term sarcopenia, which refers to wasting of muscle and loss of muscle strength that we often see with aging and some forms of disease. We know as well that environment and genes influence how we develop and how we age. There is a genetic component to aging. It's one thing we don't have control over, but there are many environmental factors that influence how we age. And this graph depicts many of them. Some of them we have control over, some of them we do not. And yet all of them have an impact on how our bodies age. Aging increases the risk of frailty. Many of you perhaps have heard of that term. It's kind of hard to pinpoint and describe. We generally think of it as a physical thing, a diminished strength and endurance. One way to view it is a state of vulnerability. It's not disability, it's vulnerability. Now, one thing we also have learned to recognize is that people with HIV are aging differently. We don't exactly know why, and we're trying to look at this in different ways. This is a study that just came out from what's known as the COBRA collaboration. That's a Dutch and British study. And in this study, they looked at aging at a molecular level, looked at changes in DNA and in some of the production of some of the hormones, and they had a big population database. So they had a rough idea of what changes would occur at what age. And on the left, you see that dashed line as the baseline, as what they would expect to see general population level. And what they did was they compared samples from people who had HIV, from controls in that COBRA study who did not have HIV, and BD stands for blood donors. They also looked at the blood of blood donors. And they, in evaluating the DNA and the molecular makeup of the blood tests, they suggested that people with HIV had an age, what they called an age advancement of somewhere around 15 years. Those in the study who were the controls themselves had an age advancement probably somewhere between 5 and 10 years. And those who were blood donors, selected for being extra healthy, were actually better in the opposite direction. Were a bit healthier than average. On the right side, the graph shows that so-called age advancement was seen no matter what the individual's age was. So the dark black line there represented the people with HIV, and there was age advancement whether they were 50 or whether they were 80. So one way to look at this, and the newest way people are starting to look at this, is by saying, well, if we look at changes in DNA or changes that reflect the general physiology of aging, do we see differences? And they do. Another way that we have seen aging and HIV interact is with the START study. You may be familiar with the study that has changed care of people with HIV and encouraged everyone to start immediately as soon as they are diagnosed. This study looked at the rate of adverse events based in 3 different age groups. So to the left are those under 30, in the middle those between 30 and 49, and on the right those who were 50 and older. And what you'll notice is that there is a difference in adverse events between those who started antiretroviral therapy immediately and those who deferred it until their CD4 count dropped. But the biggest difference between adverse events in the deferred group and the immediate group was seen in people who were 50 and older. In this case, at 3 years, the difference between 3% and almost 12%. If you look at HIV and aging in terms of the medical problems people have, what we call comorbidities, there are a lot of data showing that people with HIV have more comorbidities than their age equivalents. And this is a study, again, a Dutch study, the Age HIV cohort study. And the way to interpret these columns is that on the left depict people who are HIV infected, and on the right HIV uninfected. And the red color represent the percentage of people in each age group who have 3 or more comorbidities, 3 or more medical problems that are not specifically related to HIV. And if you compare in particular the 2 bars that are in people over 60, the rates of multimorbidity, the rates of people who have 3 or more or 2 comorbidities are much higher than those who don't have HIV. This study shows that things haven't changed very much. They compared groups between 2006 and 2014. Again, in each case, the further right you go, the older the population is. So if we can go through this, let's take a look at, for example, hypertension. Group 1 is the under 30 group. Group 5 is the older 60 and older group. And then the gray is 2006 and the black is 2014. So in certain cases, the group in 2014 has a higher prevalence of hypertension than the group of people at the same age who were at the same age in 2006, but that's not always the case. So, for example, slightly less smoking, for example, in this group, and slightly less diabetes in this group. But in general, they held the same. There wasn't a sign that after 10 years, this new group aging in was going to have a different set of comorbidities. I will point out that that the oldest group had a much lower rate of smoking, but it was still close to 25%. And we'll discuss smoking again later in this webinar. So when we talk about aging and things that happen as one ages, the comorbidities are often the first things that we measure, just because they are they're diseases that we recognize, they're medical problems that we recognize. In geriatrics, we've understood that there are things that just don't fit into specific clear categories, and we've referred to them as geriatric syndromes. We are also calling them aging-related syndromes. Frailty, what I've already talked about before, is one of them, but falls and dizziness are examples of others. And as one gets older, comorbidities are not the only medical concern. It's hard sometimes to understand exactly what we're talking about when we talk about a syndrome, and I wanted to spend a minute on that, because this new definition of syndrome is very different from the old definition of syndrome. So the traditional syndrome is exemplified actually by AIDS itself, acquired immunodeficiency syndrome, which in '83, when it was named, was rare. People knew it had to have a specific cause, but that cause was not known, and there were multiple manifestations, multiple ways people could present in their illness. Aging-related syndromes in many ways are exactly the opposite. They're very common, and there can be multiple causes. You can think of all the reasons you might be feeling dizzy, but the symptom pattern is very recognizable. So if we look at frailty as an example of a geriatric syndrome, it's been recognized in HIV for a long time. This study on the left is 10 years old and was comparing the rates of frailty based on two things. One was the nadir CD4 count, and the other was the age of the cohort. So that dotted line above was a very early cohort before effective ART was available. The other two were different cohorts where ART was available. And what they demonstrated was that the risk of frailty increased significantly as the nadir dropped. But they also demonstrated that while initiation of antiretroviral therapy reduced the chance of frailty, it did not eliminate it. It would be very helpful, and I think, to see the study replicated again as our medication becomes more and more effective and easier to take. The study on the right is a study from the ALIVE cohort, which is a cohort of injection drug users, and it compares 4 different populations. One is looking at survival. The top one, the top blue one, are the individuals who have neither frailty nor HIV, and they have the highest rates of survival. The middle two, the green and the red, which are essentially the same, the red are those who have frailty but no HIV, and the green are those who have HIV but did not meet criteria for frailty, and their survival rates were not as good as those who had neither. That yellow-orange graph is those who had both HIV and frailty, and their survival was significantly worse. There was a synergistic effect between having the HIV and meeting criteria for frailty. So frailty is again sometimes hard to measure or understand, but geriatric syndromes are there, and you may be quite familiar with them. I wanted to show some real-world data. This is from UCSF, from San Francisco, their SILVER project. These were some of the preliminary data they obtained before they started their Golden Compass program, reflecting that older people with HIV have multiple problems, many of which are not necessarily a specific disease, which may reflect, again, geriatric syndromes. And in this group, 30% were smoking. The median number of medications was 11. 40% had fallen in the past year. About a third met criteria for some cognitive impairment. Many were lonely, many were depressed, and many lacked social supports. If you look at the table over on the left, you can compare the 50 to 59 age group with the 60 plus age group, and it's pretty much what you would expect, that those who were over 60 had more problems with balance or health than their younger counterpart, with one exception, and that is they were much more likely to adhere to their medication regimen. Their rate of poor med adherence was very low. And sometimes if the clinic is very, very focused on medication adherence, older people will do so well that their other needs may not be listened to. So this is a wonderful thing. It's kept HIV under control, but one of the things that we're all trying to do is broaden the concept of health to include more than just viral suppression. Older people with HIV have non-HIV related neurocognitive disorders, and this is a complicated graph, but I wanted to walk you through it because it reminds us that the kinds of cognitive problems that were occurring early on in the history of this disease were very different from what we're seeing now. That so much of the problem was due to active HIV replication in the brain or ongoing neuroinflammation in the brain, as well as just damage to the brain before initiation of the retroviral therapy. What we see now is that these haven't disappeared completely, but that what is more and more responsible are the things that affect us all: cardiovascular disease, other neurodegenerative diseases, drug, alcohol use, and as well, perhaps, although we don't know for sure, we don't understand what the role of antiretroviral neurotoxicity may be playing, but we can't rule that out. So there's one other point that I want to make, and that is that aging also adds just one more stigma to the other stigmas and leads to more social isolation, so that older people with HIV are less likely to disclose their status to relatives or other loved ones than younger adults. They're more likely to live alone. They're less likely to seek out social support from family and friends. This combination of HIV stigma and ageism may affect women less. We're not sure, but age doesn't make other stigmas go away. It adds another dimension, and one of our responsibilities is to try to understand how all that works. So if you the way I've put all this together, when I look at the components of health and well-being, we can start on the bottom left, with the biomedical problems, which is, kind of the way the doctor views things. What's the role of HIV, the role of multimorbidity, of polypharmacy? What kind of prevention should we be doing? What are the aging-related syndromes I should be looking for? But that's just one corner of this. There are a variety of psychiatric problems that we must address and recognize, and not just depression, anxiety, but insomnia and PTSD. We need to screen for them. We need to be able to help people who have them. There are a variety of existential losses and concerns that people have, and loneliness has been written about a great deal. One of the concerns that we have had, that we've noticed a lot, is the sense of abandonment. As wonderful as the emphasis on PrEP and UH=U has been, I have had patients who have felt that they've been abandoned in this effort to focus entirely on viral suppression, and the bottom line is that nothing precludes anything else, that all of these things are important. One is not more important than another. There are unmet practical needs. There are a variety of social stressors, some of which we've talked about. There's just general wear and tear from chronic pain and from exhaustion. And of course, all those psychosocial variables interact with the biomedical variables and affect health and well-being. So as I've become involved, I've sort of felt the field of HIV and aging is evolving, that it started because we first had to recognize just the general demographics, that the proportions were changing, that people were aging with HIV, and that we needed to understand what was happening. That led to a focus on comorbidities and multimorbidities and the medical care, but what we need to look at now, again, is how to help with the aging-related syndromes and how to prepare for long-term and other social needs. Now, one possible solution to this is consulting a geriatrician, and I have the definition of a geriatrician here for you, which is the official definition, but not enormously helpful in trying to understand, who we are and what we do. The leadership in Canadian and American geriatric societies, as well as the British geriatric societies, has tried to explain us in a better way, and they say that geriatricians concentrate on what they refer to as the 5 M's. Mind, that is both cognitive and emotional state, medications, multimorbidity, mobility, and what they refer to as matters most. That is going back and trying to understand our patient's quality of life, what our patient's priorities are, and trying to address the medical and other matters in the context of what is most important to the patient. So we've had an HIV and aging program almost since 2012. It started out with conferences, and then we got some foundation support from Samuel's Foundation to begin to embed geriatricians in the Center for Special Studies, which is Cornell's HIV practice. We also had some arts programs and other socialization programs. Two of us continue to see patients at the HIV practice once a week. And what we're working on now, trying to figure out, is how we create and sustain community linkages. And I just wanted to show you some of the things that we found. These data are a few months old, but they're reflective of our consultations. The commonest reason people are sent to us is that they have complaints of memory, poor memory, or they're worried about their memory. But we talk about many things. community services, other medical problems. We talk about function. We talk about continence. We talk about smoking cessation. I've talked about retirement, caregiving. The list is broad, and one of the things you won't see here is I don't talk much about the antiretrovirals. I leave that to the experts. I want this to be an opportunity to discuss other things. What I learned pretty early on was as we talked, that it was very important to talk about goals, and so every new patient I just ask, what are your goals? And the tallest bars here are, reflect really very fundamental goals. Staying alive, figuring out how my finances, getting a job. There are a number of other goals that can be travel or caregiving or artistic. But the other thing I want to point out was many people were unable to tell me even one goal, and that to me is one of the greatest tasks we have to work on, which is as people age with this virus, finding ways to continue to bring life meaning. A few other things we found is about 40% rated their health as fair or poor, and about half are living in at least moderate pain. So there's a lot to do, and what we have tried to do as geriatricians is help reshape the care. If someone sends a patient to me worried about memory, I can be there to confirm suspicion, or I can help uncover problems. I can introduce resources. I can help with the patient's help establish priorities and convince the primary care provider to begin to focus on what the patient's been trying to articulate but hasn't been able to. We can talk about different medications that may not be as toxic, or we can talk about trying to reduce the total number of medications, reduce polypharmacy. That's something that's now termed deprescribing. But again, we want to help people articulate their goals and focus on them. Now, I'm a geriatrician, and I love what I do, and I would love to see everybody. I'm providing here some numbers, though, to remind us all that the workforce supply is not going to meet the demand. So this green number is the supply of geriatricians currently. This is what the American Geriatric Society thinks we need. This is the supply of cardiologists. So you can see that there's about a 10-fold difference in number of cardiologists as opposed to number of geriatricians. In this graph also, I have not depicted, but I've just mentioned that there are fewer than 2,000 HIV providers. And the graph here that I've taken from the clinician workforce survey, the red is the FTEs, the number of FTEs of HIV clinicians that are needed. The blue is the number who actually are in the workforce now, and the number has just gone down. So this number here is from 2015, and the projection is that the workforce is going to continue to decline, so that there aren't going to be enough geriatricians, and we also have to understand that there probably aren't going to be enough HIV specialists either. So as we try to figure out what to do, we have to be very realistic about what the workforce is going to look like. So I've introduced a huge amount of uncertainty as we age, uncertainty at the level of the clinic, but also if you think about what you need are there going to be providers out there for me? Is there going to be long-term housing? How am I going to transition? What are my finances going to look like? What are my caregiving needs going to be? There's so much uncertainty. One of the things that we in geriatrics are trying to do is help deal with all aspects of the future, given that we need, though, to configure a workforce that will be there for you. So at the clinic level, just in terms of what do we need to do, in your clinic, I sort of view this as a mixture of a number of tasks. The primary task is primary care, and of course there are time limitations with that. There is HIV care, there are aging concerns, and there are limitations in money and access. In addition to that, there are a number of things that the clinic must link to. One is subspecialty care. How do we link effectively to your subspecialists so that the communications work? But in addition, how do we link to social services? And clinics are generally very good at linking to the HIV services network, but not as good as linking to the geriatric services network. And I wanted to, in a few minutes, talk to you about how you might be able both to help yourself and encourage your care coordinators and others to begin to look into how to access services for people who are aging. So I asked you to think about some questions earlier on, and the first thing is, okay, so what can I do? And there are a lot of things you can, and you've probably heard most of them, but I'm going to reiterate them because they are a part of healthy aging as well. And the first is stopping smoking, which I cannot overemphasize. The second is getting exercise, and exercise can be walking, it can be climbing stairs instead of taking the elevator, it can be taking a stroll with a friend, it can be gardening, it can be almost anything, but it is such an essential part of remaining healthy. Connection, social connection and friendship, that is another essential part of aging well. Eating healthy. I'm emphasizing that smoking again, quitting smoking again, because it is just a crucial part of improving your health. Taking your medications, understanding your medications, knowing what you take, and knowing why, and making sure that you are adhering, and talking to your clinician. Making sure they understand what your needs are, and making sure you two are communicating well. What you also can do is access aging services. Now, these usually begin for people who are 60 and older. But I want to make sure that you're acquainted with what is out there. Every county has an area agency on aging, and there are ways to access it through the web. One is, and I have some screenshots here. One is the National Association of Area Agencies on Aging, or N4A, and you can plug in your zip code, and it will tell you the location of your local area agency on aging. Another is what's known as the Elder Care Locator, and I'll have another shot of that in a minute. In the past 5 years, something that is very important has grown out of a new federal policy to link federal agencies, so that the Aging and Disability Resource Center initiative links the Administration for Community Living, the VA, and CMS, that is the Administration for Medicare and Medicaid, so that all of their services are combined in one place, and it's called the No Wrong Door system, so that you can call them or visit them, and it doesn't matter which one of these you meant to access. The idea is if you are seeking services, it's one door, it's one phone number, it's one easier way of accessing them. And I think that it's been quite successful. It has certainly grown, and to my knowledge, almost every county again has ADRCs. These are other ways to determine what kinds of services that you can get. One is known as the benefits checkup. That's on the left, and that's through the National Council on Aging. And the other is the Elder Care Locator, again, which I'd mentioned before. I'd mentioned it in light of the topic of finding your area agency on aging, but as you can see there, you can search by topic, not just look for your AAA. All these are ways that you can help yourself or a colleague or a friend or a spouse or a parent try to find the services that you are eligible for. So finally, I wanted to say, well, what questions should I ask my providers? And I think this is a great project if you belong to a community advisory board, to begin to ask more specific questions about what your clinic, what your program specifically is doing for people who are aging. And these are some of the questions that I thought you could ask. And the first is, okay, who's going to be screened? Who needs an assessment? What have you determined to be the criteria for seeing an aging specialist? Who's going to do it? Is it going to be, are the nurses going to screen? Am I filling out a questionnaire? Do I have access to a geriatrician or a gerontologic nurse practitioner? Harvard's Mass General's program is run by a gerontologic nurse practitioner. You do not need to see a geriatrician, but what you need to see is someone who understands aging and understands how to look at you and your needs. How are you going to translate the assessment into action? If I need something, what does that mean? How is our program going to foster physical fitness and nutrition? If those are such crucial parts of aging well, how is that going to be incorporated into my plan? How are you going to meet the psychosocial and long-term care needs? Many of your programs may have therapists or affiliated psychologists, but linking into the long-term care system, into the aging services network is something that every program needs to think about now. What are the community-based services? Do you want to have a linkage with a local senior center or some other program that's appropriate? And how is care going to be coordinated? These are questions I thought of, and I'm sure you can think of others that would allow you to begin to ask your program how they're preparing for people who are going to age with HIV and who have aged with HIV. So here are some resources from the CDC to the NIH to HIVage.org. There are a variety of places that provide a lot of information. And with that, I'm going to take questions. Okay.
So I have one question here from Stephen Vargas in Houston. You may have already answered this, but he wants to know, I thought the most of aging differently was due to chronic inflammation. What are the other factors?
Well, I think people are trying to understand that and trying to tease apart what is due to smoking or other behavioral aspects. Chronic inflammation is certainly what most people think is part of this, or a major driver of this, but there's so much we don't know. For example, we don't know when HIV DNA, the provirus integrates into DNA. Is it altering how DNA is read, or is it causing mutations, or causing other proteins to be produced? So I think you're right in the sense that chronic inflammation is where we start, and that it's also important again to remember that there are many factors like other chronic infections, or like smoking, or other things that aren't specifically related to HIV that confound what we're seeing. But I think as we begin to look at sort of the DNA side of things, and some of the more sophisticated molecular biology, we're going to find other mechanisms besides inflammation that contribute to this. Having said that, and it's important to emphasize that people with HIV who are well controlled live near normal lifespans at this point, and the goal here is not to say that you are 15 years older than you should be. That is not the case at all. These are attempts to try to understand what's going on. Instead, what we're hoping is that as antiretrovirals are less toxic, as people start sooner, as medical care becomes more sophisticated, as the virus remains suppressed, that factors like inflammation and other things that we don't understand yet that contribute to aging are going to be kept under control.
Okay, so I have another question from Anne Marie. Have you, in your experience, difficulties in 60-plus age group of de-prescribing opioids in folks with documented chronic, moderate to severe pain, and resulting in a decline in quality of life?
De-prescribing opioids is difficult, for everyone, and there are certain aspects to this. For people, for example, who are on methadone programs, I sometimes find it a challenge to begin to encourage the methadone program to begin to lower the dose as people get older and as their metabolism changes. I think that the approach to de-prescribing with people who have chronic pain is to step back and get a more holistic approach as to the origin of the pain, and begin to look at pain clinics and other programs that have modalities other than opioids to substitute for the pain. Pain management is very difficult. HIV neuropathies often don't respond to non-opioids. It's a terrific problem, but I think that the nationwide push to reduce opioid dosage is a good thing, and that it's forcing all of us to figure out non-opioid ways to treat pain, and there are. So the answer to the question is, it is an enormous challenge, but it is also critically important, because as one gets older, the ability to tolerate these medications diminishes. And what I am hoping is happening is that the general philosophy of reducing opioids and of revisiting the management of chronic pain is going to help everybody, those with HIV and those without.
All right, so I don't see any more questions coming in. We just have one more comment that I'll read out to you. This is from Judith. It says, providers just do not want to believe people over 60 don't have sex, especially women. I think women aging are looked over. Loneliness is very real for the aging population. Aging with HIV and loneliness makes for an aging population very toxic thinking. One of the things that I'm sharing in my community is that those conversations around it's over until it's over, helping our aging population step out of their comfort zone.
I continue to talk and continue to share because these are very important messages.
All right, well, I don't see any more questions. I think we will wrap up with that. Thank you so much, Eugenia, for presenting today.
Thank you for everyone for listening, and I appreciate the opportunity to talk with you today.
All right, thanks everyone, and have a good weekend.